over 50 have an enlarged prostate, at least to some degree. And in a lot of cases, it's not because of aging or hormones, at least not the hormones that you think. It's because of a daily habit that's quietly pushing the prostate to grow year after year after year. And no one's talking about it. No one's being told about it. So it reminds me, I mean, a lot of the evidence that we're going to present today, the research that we're going to talk about today, was around 8 years ago when I started this channel. And I remember there was this new thing. It was called YouTube Live. And I had a couple of friends, they came on with me. We had terrible technology, but we talked about this topic. The only feedback I got was from one of my best friends in my Sunday school class. And he said, "No, you're all wrong. This is all testosterone." And it's like, I can maybe tell you the rest of the follow up on that story a little bit later, if we go there in terms of the discussion. But in this episode, we're going to break down what's really driving that growth, how it affects your hormones, and again, which hormones, maybe not what you think. Why symptoms like urgency and nighttime urination start showing up, and what you can do to stop it before it gets worse. At the end of the day, it's not that everything is bad news. There are opportunities as you begin to look and find out what's causing health problems. Jesus, you ready to come on board and talk a little bit?
Absolutely. I'm so proud of you, Dr. Brewer.
Why is that?
You went through that initial introduction really, really well. Fantastic.
Oh, good. I'm glad you liked it because, well, I was going to say something snarky and smart aleck, but I'll.
You never do that.
Never.
Let's go ahead and somebody said, get the cat out of the bag. The title of the video is "There's one specific habit that is enlarging men prostates all over the world." I just saw this statistic and I was amazed about it. Up to 25% of 30-year-old and older have this issue, enlarged prostate. Mm-hmm. And when you reach 60, that number goes to 50 to 60% of the men, which it's an outstanding number. And we kind of wanted to share with you what's that specific one habit that 90% of Americans are doing every day that's contributing in a major way to have an enlarged prostate. So let me share this small image with you guys. This is an enlarged prostate, right? The prostate is that organ that's below the bladder and that's around the urethra, and which primary function is to create semen and also provide fructose for the sperm to have some energy resource for their long travel after they're being used, right?
So the prostate actually makes fructose?
Yes,
it does. I didn't know that. That's interesting.
Yeah. And let me just adjust the image a little bit because I would like to have us, well, we're both in there, but we're really small. Anyway, so there's one specific hormone, which is not testosterone, that's driving this issue in the background. Of course, testosterone plays a big role, and we're going to discuss testosterone in a minute. But insulin is probably the most important hormone related to enlargement of prostate. There's this specific, another hormone called IGF, insulin growth factor, which when it gets stimulated by insulin itself, can increase the amount of cells in the prostate. And that's something else that Dr. Brewer and I, we were discussing. If you get technical about the definitions, when we talked about enlarged prostate, we're talking about BPH, which I have made this mistake before. We sometimes call it benign prostate hypertrophy, when the real name or the actual more accurate name should be benign prostate hyperplasia. And all those tricky words basically mean two different things. Hyper is more of. Hypertrophy means growth, but it's when one cell grows and starts creating this mass within the organ. Plasia is different. Hyperplasia is not that one cell is growing. It's just that you're having more cells around, and you have a bunch of cells, and then they clump together and create this big ball within your prostate. So that's kind of a technical, geeky thing over there. But this enlargement of prostate, benign prostate hyperplasia, is directly influenced by insulin with this mechanism, but it's not the only one. There are two other major mechanisms in which this happens. And if I'm getting too geeky, just put it in the chat. I believe Dr. Brewer can go ahead and clarify for me. What happens when you have high insulin in your liver?
Well,
Yeah,
I'm
go
going
ahead.
to interrupt and say,
Please.
yeah, I thought that was really pretty geeky, especially the part about hyperplasia versus hypertrophy. But in case people missed it, I wanted to repeat what you said.
Go ahead.
Insulin. In other words, high levels of insulin causing a swollen prostate. That's what you said, right?
That's correct.
And that's what I said 8 years ago. This is not new information. So at the end of the day, you're talking about insulin resistance, diabetes, prediabetes, Fruit Loops.
Come on, you just give it away. Okay. Well, we'll talk about we'll talk about later about the causes on insulin resistance and what we believe are the major causes.
Okay.
But we wanted to put the picture out there. If your insulin is high and you're having prostate issues, well, that might be the missing link that you didn't have. So let's go a little bit onto the geeky stuff yet again. So when you have high insulin and your liver gets that message, it will downregulate, meaning it would produce less of another protein that is called sex hormone binding globulin. That's SHBG. And when that globulin is low, that promotes that you have more testosterone, more free testosterone in your bloodstream, which for an old person it might look like a good thing, right? High insulin, more testosterone, that's a good thing. Problem is, within your prostate, there's a specific enzyme which turns that testosterone into something else. And that enzyme is called 5-alpha reductase. So that alpha reductase, when it senses that it has too much testosterone around in the prostate, it turns it into DHT, dihydrotestosterone. And this DHT is what triggers the most the growth on that prostate. So if you say, okay, it's too much testosterone, that's what's causing this, it could be, but also just see above on this train of events how high insulin is actually promoting this. This enzyme right here, 5-alpha reductase, that you see in the middle of the screen, it's very important because that's the one that turns testosterone into DHT. And this is what the current medical standards focus on whenever somebody has enlarged prostate. If this enzyme is turning testosterone into DHT and that's causing enlarged prostate, let's just go ahead and block it. And one of the medications that does that is finasteride. And that's something that's usually into medical arsenal to minimize this problem. But if you have been around the channel enough, you now know by this point, finasteride doesn't do anything with insulin resistance. And you might reduce the impact on prostate with that medication on this specific pathway, but you are ignoring the others. So we have seen two pathways so far. Do you have any additional comments, Dr. Brewer, before we go to the third way insulin resistance is causing enlarged prostates?
So you're saying the testosterone is actually high?
Testosterone is actually high, and there's some regulation. Like the body is smart, and high testosterone doesn't necessarily mean that you're going to have higher DHT. Actually, in old people, testosterone levels are lower, bloodstream testosterone levels. But within the prostate, this enzyme 5-alpha reductase actually is overworking and turning much of that testosterone into DHT. So you have low testosterone in your bloodstream, but you have high DHT inside your prostate.
So that's what I was getting at. Most men are comfortable with, or at least accept it as reality, that they have lower testosterone than they did when they were in their 20s and 30s. Most 50-year-olds, 60-year-olds, even 40-year-olds. But then now you're saying that prostatic hypertrophy or hyperplasia is caused by high testosterone. How does that connect? And you just explained it. In case folks missed it, the bottom line is inside the prostate is a very different environment from outside the prostate. As we were discussing before the show, you've got the blood-brain barrier, where a lot of things that are in the blood don't make it into the brain because of the blood-brain barrier. You've got a very similar prostatic barrier. And that's one of the reasons why prostatitis, infection of the prostate, can be so dangerous. It's very difficult to get antibiotics to penetrate that prostate barrier.
Fantastic. And this is the third mechanism. High insulin will promote high visceral fat. And within your fat, there's a specific phenomenon where testosterone that goes into the fat can get transformed into estrogen because of an enzyme called aromatase. So that high estrogen has specific receptors into the bladder, and when you have high estrogen, it can promote stimulate some of those receptors in the prostate and cause more cell growth, more hyperplasia, more enlarged prostate. So that's another mechanism in which insulin can go into this process and enlarge your prostate. And now I think we're ready to get the cat out of the bag. But although Dr. Brewer already did, what would you
sorry
say
about
is
that? Before you do, let's go back and get up to about 50,000 feet again. Three mechanisms. Sure. One is insulin. Insulin is the ultimate growth hormone. It's what makes the cell go into hypertrophy, swelling up, growing, getting larger. And even more so, its twin brother or cousin, IGF, insulin-like growth factor. Both of these are stimulated with prediabetes, with insulin resistance. That's item number one. Now, what were mechanisms number 2 and 3?
Second mechanism was the impact directly into testosterone, because lowering SHBG, sex hormone binding globulin. And the third one is the impact on visceral fat and high estrogen. And if you notice this one, I didn't mention it, and I should have. This specific mechanism can also promote inflammation. So it's not just the growth of multiple cells within the prostate; it's also the inflammatory response on this.
And growth has a significant component of inflammation as well. It is insulin and IGF both are inflammatory hormones.
Yep.
They stimulate the growth of immune cells, and then all the stuff that goes along with that, which is inflammation, which is not always a bad thing.
Correct. Now, I was getting ready to just get the cat out of the bag, as we said. What will you say is the major driver of insulin resistance?
Well, genetics, age, and body composition. And body composition starts from eating a lot of carbs, right?
Exactly right. I'm glad that you mentioned that, because I was about to say, well, remember how we always say Dr. Brewer doesn't agree with everybody? That will include me. But I agree with you. But I agree with you on the side of those are the three major components, right? You have a genetic issue, you have a aging issue, and you have a body composition issue. But I will argue that the last two are highly impacted by this. And even the first one, your genetic component might be impacted by what people coming before you used to do. And I know what you're going to say, guys. It's the 100 and something people who are watching the show at this very moment. You guys let me be clear. I think you are in the minority of people that do not consume these things. You
Hmm.
probably did at some point in your life, and that's something that you kind of keep getting the impact of that into your prostate. Remember, we said this is not that prostate cells are growing, it's like you are producing more cells that get clumped with each other. And you can have such a big prostate, but the problem is how much does it obstruct the urethra where the urine and semen goes through. Research has shown that people with diabetes can grow up to 10 milliliters volume of prostate. And people who are eating around 150 grams of these processed carbohydrates a day or more are having more problems, or are in more danger of this problem. 90% of US people are eating refined carbohydrates every day. So even
90%.
90%.
And
So
how big? 10 milliliters. How big is that?
that's a lot.
You know how big it is?
How big it is? Can you give me a reference point?
A ping pong ball.
Come on, that's huge.
That's what I said. I was reading this, going back and prepping for the background on this, and that's what it said. It said, look, a typical diabetic male or significantly pre-diabetic male is going to have a ping pong ball worth of extra prostate tissue. I thought, gosh, that's a lot. Go back and show the picture. You can take me off, but show the picture of the anatomy where
I can keep you there.
the very first slide. Yeah, there. Remember, those of us who've had prostatitis, and I've had it a few times, get a very painful understanding of what that means. You can't pee. Or when you get prostatitis, the minute just a tiny drop of urine goes down into the neck of that urethra, you get major pain, and you end up wearing a diaper until you get over that problem. This can get ugly.
It can. And this is the major point. You can have such a big prostate, and that will increase your risk of that prostate pushing your urethra. But you can also have a small prostate and still push your urethra because of inflammation. So you can have both the scenarios. But what we have seen is that people with diabetes are more prone to have these large amounts of prostate. And it has been shown that usually insulin resistance is driven more quickly when somebody is consuming those refined carbohydrates, 150 grams a day.
So back to some of the other conversation we were having, one of your favorite rants is about what? Breakfast cereal.
Breakfast cereal.
Fruit Loops, Cheerios. I hope I'm not going to get us demonetized mentioning these brands. Lucky Charms. What were the brothers? The something mix.
Kelsey.
The Kelsey mix. And again, that information, those rants, occasionally did okay, but more often than not fell flat with our audience, because I think you're right. Our audience just doesn't eat that stuff anymore. But what surprised me was the number of people that do. What's the number that you said? Eat cereal?
Oh, it's cereal. I revisited that number, but it's over 50%. Maybe not on a daily basis, but it's a common breakfast.
On a regular basis, like half of us eat cereal, eat that junk. And if you're saying, okay, well, that doesn't bother me because it doesn't impact me. What about you? Do you have kids? Do you have grandkids? Do you have nieces and nephews? This is a bigger issue, and it touches more of us than we realize. And I love to beat on Jesus for saying that, that comment's falling on deaf ears, but it's frustrating. It's worth going ahead and having that rant about cereal anyway, because it's doing so much damage.
Yep. And I can tell you, I mean, unless you have been doing a low carb diet since you were 10, which I highly suspect hasn't happened, you do prime your body within the years into promoting some of that insulin resistance, and you can get better at it. But most people will be having this issue because they're carrying that from 20, 30 years from now, or even more. There are the main cause for BPH that's out there is usually thought as testosterone, but also driven by aging, as you just said on the introduction. And we're making the point that on the current society where we live in, this is something that is increasing how this is a problem. And for most people, it is. So what we're asking you guys is, you can go ahead and share this video for somebody who is not aware of this, and just skip to the part where we say this if you want, if they don't have time to look at the science, because you're all here science geek. But we're trying to make a difference and just make people understand this goes beyond just some of the major complications like blindness, erectile dysfunction, heart attacks, and strokes. Stuff like prostate can be a big issue. I don't know if you want to share this, because as we said, Dr. Brewer, you are one of the weird examples of somebody who has walked the talk. You have been through this. You know this already. You have been doing low carb for years now, and this is not something that gets easily reversed. You manage it. You were able to manage that. You shared with me some of your story on your bathroom trips, and you're getting better at it. And I know a lot of people who are watching the show right now might feel that this is a relatable story. You're peeing to every night. Now you're not peeing during the day, you're peeing during the night. That messes up your sleep and brings another cascade of unfortunate events. Want to share a little bit about your personal journey in regards to prostate, Dr. Brewer?
Sure, we got a lot of stories that we can tell about that. One of the things that that it's not personal, it's how common this is. After we started doing videos on low dose tadalafil, Cialis, it's amazing the number, just one or two videos about it, and guys started asking for it a lot, and to the point where I don't know, what portion of guys do you think we have that are on now on low dose tadalafil?
You're talking practice wise?
Mm-hmm. Over half.
I would say probably less, but you're
Really?
the one who you're the one who prescribes it, so I'm not sure.
I think it's over half.
Yeah.
On a personal story, I remember the first time I had prostatitis. It was like I ended up in the ER. I woke up with incredible pain at like midnight, and I went to the bathroom and started to pee, and I noticed that there was blood in my urine, and what was interesting was I started to get faint. I've never gotten faint with pain before. I've got a really good pain tolerance, except around my prostate. And there have been multiple times when I've had prostatitis, probably 4 times, 5 times. My first time I was maybe in my 30s. And you say, well, dang, what's going on with you? Why do you have that that risk? I don't know. I do know this, that I didn't eat a whole lot of Fruit Loops. That wasn't my issue. But I did, as we've discussed about my prediabetes and diabetes, I had a low HDL and a relatively high triglyceride from the very beginning in my 30s. So we know, we didn't know we didn't know then what we know now, but that's clearly a sign of diabetes, prediabetes. So I'm one of these guys that was thin, always worked out a lot, but I had prediabetes, probably did. And so, no, I wasn't eating Cheerios, but I was eating bread. I wasn't eating pasta, but I was eating bread all the time. So
Mm-hmm.
it was a low fat diet. And so I traveled a lot for my work, and so I had to eat out a lot. And for me, one of the safe, and I would pork up if I would get big if I ate regular food at a restaurant. So I would
Yeah.
always just get a salad. It was, even back then, 30 and 40 years ago, we valued omega-3s. So it was usually a Caesar salad with a piece of salmon. But
Yeah.
for the most part, a low fat diet. Well, if you're running half marathons, I was doing at least a half marathon a week, because that was the other thing. We thought that long, slow distance was the thing. And long, slow distance, yes, it's not a bad thing unless you get some arthritic related issues, some
Mm-hmm.
repetitive stress. But we've found out over the past decade or two that high intensity interval work, resistance training, those are a big deal. I wasn't doing that. We found out that low carb is healthier than low fat, and we'll probably get beat up on for me saying that. So I was doing a lot of stuff wrong, and so I was eating a lot of bread. I needed to get calories somewhere. I wasn't getting them through fat. So instead of eating my whole point is, I'm going down a bunch of small bunny holes, but my whole point is I was eating tons and tons of bread. Wasn't eating pasta, wasn't eating cereals, but lots of bread.
Yeah. And do you think that drives some of your prostate issues?
Well, I know that I was pre-diabetic for decades.
Mm-hmm.
So yeah, I think that's a major point of what happened with me. I think that's why I've got a more risk in terms of prostatitis than a lot of guys.
Yeah.
And as I mentioned, it gets ugly. You end up, if you're having that kind of bleeding, the vagus nerve, the prostate has very rich innervation by the vagus nerve. So that's probably why I was fainting, even though I had a good pain tolerance. It was either the second or third time that I had prostatitis. I fainted again, almost fainted. I was sitting in a chair, and it was like some of the pain started coming back, and it was like I saw my kids. They were peeking out the door because they'd never seen Dad do that, and it's the only time I've ever gotten started having problems with consciousness.
Yeah,
And I remember waking back up and looking at the two kids, and they're looking out the door like this, going, "What in the heck's going on?"
I remember you shared that and another story on that if you want to share that one. But just to clarify, prostatitis, even though it's not necessarily the same thing as BPH, this is an infection. It's an inflammatory issue, which you can get more prone to if you have insulin resistance. It is widely accepted that diabetes immunocompromises your system, meaning your defenses are low. We do believe that insulin resistance can do that even if you don't have diabetes, which is kind of the major point we're trying to make here. You don't have to wait to develop diabetes. You don't have to wait until your fasting glucose goes over 126 to have this kind of risks around you on metabolic disease. Just a reminder, it's estimated that only about 7% of the US population is actually metabolically healthy. So most people are dealing with this problem. All right. Do you have another story on prostatitis that you want to share, or you're good?
I think I'm good. I got plenty of stories on prostatitis, but maybe I've shared enough. Unless you know of some that you think would fit.
I was just gonna talk about medication, but I think that's another bunny hole we don't want to go to. Just about ciprofloxacin and its effect on tendons and how that damages and puts you on danger of getting injured. But I think that's a whole nother conversation point.
Well, you and it was either the last time or the next to the last time that I had prostatitis. We went through that discussion because I've seen too many patients that had tendinopathy. Well, you're getting to the point that I made earlier that a lot of antibiotics just don't penetrate the prostate.
Mm-hmm. and the ones who do, they might have some side effects. And that's the issue. If you can take care of your metabolic health, that will prone you to have less risk of all sorts of medical issues, from heart
Yeah.
attacks or strokes to prostate infections to all this other stuff. There is risk, of course, but the point is to minimize it. And that's why I was talking about Dr. Brewer walking the walk and talking the talk. Just like he has trained me, he has trained another set of health coaches who have a very strong background, and they are doing the way stuff the way Dr. Brewer does it on a health coaching aspect. So if you're looking to have a second opinion or a third opinion regarding your metabolic health, give us a call, 859-721-1414. We have a specific team and we have specific programs that might fit you. 1-859-721-1414. That's the right number right there. And you will get somebody's going to answer the phone and explain you what this is about. And based on what you tell them, they might be able to tell you which program fits the best for you. Dr. Brewer is still seeing patients, but we have other options. We have a couple of nurses who are working with us who have been trained by Dr. Brewer, and we have a group of health coaches who have also been trained by Dr. Brewer, just like I was. Any additional comments on this one before we go to the Q&A, Dr. Brewer?
Well, like I said earlier this morning, we need to get some more of those health coaches out in front of the team, the audience, the viewers. We've had Bernie. We've obviously had you a lot. I don't think we've had Jose, have we?
Monica, no, we have had Debbie, which was a home run.
Debbie came out.
Next week, you and I are going to be traveling. So we recorded an episode with Bernie, Dr. Bernardo, who will be here as well next week. Jose,
that's going to be about statins, right?
Statins. Next week is going to be about statins. And we had Miranda, we have had Heather, and we're looking to bring them back on the show again. Working on that as we talk.
So with the show that we did with Bernie, the statins thing is, if you don't like statins, you might like this show. I don't know whether the best title is "Are Statins as Bad as You Think" or "Are They Worse?"
Yeah, and you and I have talked about this. We have a very conservative view about statins. Nowhere near current medical standards advocating for high dose statins, but we're also not statin haters. We try to have kind of a balanced view on topics. But that show, it's going to be an interesting one. All right. So, Aspen, why don't we go ahead and show that squeaky plaque thing that we need to fix later? I remember every Thursday and then I forget to change the sound and all that stuff. Aspen, let's put it on my calendar and get that thing fixed. Want to give a shout out before we go to questions. Gary Paladin, thank you so much for becoming a member. And Patrick Sullivan, thank you so much for becoming a member as well. As members, if you ask a question, we will answer them first. And we have some exclusive member content for you. We're working on more videos for you. We're just trying not to flood you with videos every Wednesday. We're going to be publishing an exclusive member video every month with a bunch of questions that you're asking and answering those for you. We have 2 memberships, $5, $10 a month. They go a long way. But if you don't want to become a member, you can still get some of your questions answered if there are good questions or Dr. Brewer wants to go there. Just click the join button next to the subscribe button. Or for some people, they will have a subscribe plus button in there. You click in there, now you're a member of the channel. This is not YouTube Premium. This is being a member of the channel. All right. So I wanted just to acknowledge JMK questions because it's one of the viewers that always brings a really good question at the beginning of the show. What do you think about vitamin D supplements for prostate cancer?
I'm not familiar with any vitamin D supplement evidence indicating that they accelerate the disease.
Yeah.
Are you?
Not that I know of. I know it might reduce. I know it reduces the risk of BPH as well. It has some anti-inflammatory effects. I haven't seen a specific study that says, yes, randomized controlled trial, vitamin D and less cancer. I know there are a couple of observational studies where people who have less cancer just happens to have higher levels of vitamin D. But other than that, I think we can agree supplementing with vitamin D when you have low levels, it's a good thing to do.
The short story on vitamin D, maybe it's a short story and I'm going to make it too long, but the bottom line is
that. Never.
I go down a bunny hole and I forget where I was headed in the first place, but the bunny holes are fun. And bottom line was vitamin D was originally discovered 100 years ago, and they found out that it prevented rickets. Rickets is a really bad disease where your shin bones come out. They bend up shaped like sabers. So relatively small amounts of vitamin D can fix that or can prevent that. And that's where vitamin D originally was focused on. But then it became clearer starting 20 years ago. This is not new. This is not past 5 years. This is a couple of decades ago. It became really clear that vitamin D does a lot more stuff than that. It's very much involved with a lot of core metabolic issues. There's a lot of evidence that it prevents metabolic disease. We've been in a couple of these debates already, and we did a full YouTube live on vitamin D about a month ago, and it was one of those vitamin D shows where one of the YouTube content creators was saying, "Oh, it's okay to do it really, really high," and he's a guy that folks love to beat on and do fact checks on. The reality was he brought in a good consultant who's got an interesting perspective on it, and so there is a case that maybe it is healthier at higher amounts. We don't recommend it. Bottom line is there's something going on with vitamin D, but despite all of that, I've never seen significant evidence showing that vitamin D was actually linked to creation or acceleration of cancers.
Yeah. And I think it goes back to any medication and most supplements. They can be good depending on what you're using them for, but most medications and most supplements are not free of risks and side effects. So if you want to go even higher, that's fine. Just know what could happen if you do so, and you titrate that risk according to your needs.
Oh, there's no question. I've had more than one patient come to me with vitamin D levels higher than 100, 115, 130.
I think we saw somebody on 200 and something. Yeah.
And recently one that was on 150, and not all of them. Some of them had no problem, but a couple of them had kidney damage. It was damage that was short term. That we got them off the vitamin D, got their level back down, and their kidney function came back. But that's real. It was not real. We saw it ourselves, and it's something to be aware of.
Yeah, definitely. And as we said, we're not here to argue with anybody. We basically don't agree in everything with anybody, and that's okay. So Max and Lucy Productions, thank you so much. Good morning from Florida. Richard Militello, good to see you here, Richard.
Good to hear from you.
Yeah. Take ADSR. Oh man, I'm gonna let this one to handle.
It's a hard name to understand.
Yeah. How often do normal or low fasting glucose and insulin levels become abnormal after an OGTT that measured both glucose and insulin?
You're hesitating.
Trying to understand the question.
Yeah, I'm trying to understand it too. I think what the question is okay, high levels of glucose cause upregulating of insulin insulin resistance. I think that's what the logic is behind this question. So therefore, if you give somebody a high amount of glucose because you're doing the OGTT, the glucose tolerance test, how often does that one test change their insulin sensitivity? If that is the question, it doesn't. that's not enough of a challenge. That's not enough of a raised a raised glucose level to upregulate it. You need days and at least hours. That video with Del Franzo, he talked about specific amounts, and I don't remember the amount, but it's not the glucose involved with 1 OGTT. That is not going to upregulate insulin resistance.
Yeah. It gives us some information. Some people might be too influenced by getting some taste of sugar, then they can go back and binge on carbs after the test. Some people don't want to do the test because of that. But it's not the test itself that's going to drive more insulin resistance.
In other words, they start going back down that addiction, the glucose addiction, sweets addiction.
Yeah.
Whole.
I wanted to acknowledge this one question. Polio Shack. Great info. How can I know what the size of my prostate is? An ultrasound is usually a good way to do it. It's non-invasive, as non-invasive can be, although it might not be as comfortable. It depends on who's doing the ultrasound, but an ultrasound can give you some good information without doing too much.
Now, wait a second.
Yeah, go ahead.
Truth be known is saying imaging, which you just mentioned. What's DRE? Digital rectal exam. And the assumption, the assumption that you're getting a good understanding of the size of your prostate from that is that's too much of an assumption. Now so what you can get though is a good idea of whether or not there's hyperplasia, whether the thing is large, but you just can't tell how large.
I can give you some insights on DRE, because that's what you and I were taught on med school, right? You reach 40, 45 years old, there's no way to escape the finger.
Right.
You got to do it. But this is maybe just because I don't want to go through that. I saw research years ago from a German paper where it showed that PSA was more specific than the finger testing, and combined with an ultrasound can give you really good information about risk of cancer. Yeah. I know that back in the day, I was taught that the rectal examination will help you identify the texture of the prostate, and that was kind of a subjective way to identify. If it was not soft and fleshy, it was hard like a stone, that was a problem. But I would argue that that's probably on a very advanced cases for which probably PSA is already very high.
It's too late anyway. Yeah,
exactly. So just most of the audience probably already went through this. So I feel for you. I'm just trying to escape myself from that.
Yeah, well, that was where I was going as well. There's a whole lot of evidence. Don't rely on digital rectal exam for your as a definitive study. Even if your doctor says it is, it's not.
Yep. Do you understand this one? I'm not sure. Take ADSR. Jesus demonstrated prostate size that was fishermen show their catch size. So I was sharing prostates like I was sharing big fishes when you catch them, or
I have no idea. I don't know what that.
Not sure.
I missed that one.
Maybe we should have done a show on different prostates, right? How did they look like? Take ADSR. My Stella just alerted me to a spike 30 minutes ago. I ate sourdough toast with macadamia nut butter, 20 carbs total. Interstitial glucose rose from 105 to 150 so far. What are your thoughts on this one? I have something that I want to say about this, but I want to hear from you first.
Okay. So you know it's always easier to go last.
Oh yeah.
But because you give the other person time to screw up.
And I give you a hard time if you do.
And you get to criticize, look at what they did and criticize. It's far easier to do that than it is to speak first. But I'll tell you, my first reaction is, number one, I don't trust sourdough food. I trust homemade sourdough a little bit more, but I clearly don't trust bread that's labeled as sourdough. You know, as I mentioned earlier in this show, grain products were a big deal for me. Not pasta, not pizza, not rice, and certainly not breakfast cereal, but bread was a big deal for me. So I looked hard for other types of bread, and I don't trust sourdough. The other thing that I don't entirely trust, I do eat macadamia
Come on, I'm the one who doesn't speak English.
I know. Well, I don't speak English either. I speak American Southern. Anyhow, that macadamia nut butter. Be careful with that too. So that's my reaction when I hear that. It's like, do you really think you didn't get any carbs? I'm not so sure.
How low carb is that, right? I mean,
right.
We can still say 20 grams is low carb, but the difference is what's the glycemic load on that combination. And also the glycemic load also kind of has challenges because it will depend on every person to know the response. There's one point that I want to make in here, because sometimes we get criticized as a Mexican influencer calls us keto crazy people, something like that.
Oh, really? Who was that?
It doesn't even matter giving them some space. The guy is just a traditional nutritionist.
I think we've graduated when we get other content creators criticizing our stuff.
Not to us. Just in general.
Okay.
General keto low carb people. But there's one thing in which I agree with Dr. Gil Carvalho, our friend Gil Carvalho, which is also mainstream media. But I do agree with him. He did a video criticizing the glucose goddess. And I personally like bashing into people like that. That's something that we don't necessarily do. But there's one point that I agree with, which is I'm not personally concerned about a single glucose spike. Like if it goes to 150 and then it goes back down quickly, I think that's kind of physiological. That's okay. I'm worried about having constant spikes during the day that are constantly peaking your insulin, that are constantly keeping your insulin above threshold, and that over time are going to become a problem. So it's not the one glucose spike that's a problem. It's the perpetuating high levels of glucose and insulin over and over again. And that's why binge eating and eating too much every day and getting your glucose over 150 continuously, that's when that becomes a problem.
Oh, clearly. And I would agree. I think, it gets back to the question that we had before about, well, will a single glucose challenge test crank up upregulate, increase your insulin resistance? And the answer is no. But how about having a glucose level of 180 for 3 hours, 4 hours, 5 hours, 20 hours, day after day after day after day? No question, it's going to upregulate. It's going to cause insulin resistance.
That's you went exactly to the point I wanted to make. If you're on your 20s or 30s and you say, oh, I just ate a slice of pizza, my glucose went to 150, but it went back down like 30 minutes later, I'm healthy. Maybe. How much insulin did it took to do that? And then as you progress, then it doesn't take 30 minutes to go down. It takes an hour. Then it takes an hour and a half. Then it takes 2 hours to go down. That's how insulin resistance develops. You don't see it at the begging.
That's one of the things that we see because we do so many OGTTs and we have so many patients in this space. That one of the most common places to be in early diabetes or pre-diabetes is that your blood sugar is not going up that much, but your insulin is. I saw somebody earlier this week whose blood sugars were basically almost normal, but his 1 hour insulin was shooting up close to 100. And the 2 hour insulin was going higher. It wasn't coming back down. So this person is that your pattern too?
My pattern went back down. My insulin has never gone over 50, but I was heading that way.
Okay.
Yeah.
But that's what this person had. And so he could measure his glucose and it would look fine. Meanwhile, his insulin was cranking, and cranking enough on a regular basis. If he doesn't eat right, to where he's going to be increasing his insulin resistance just from upregulating it because of having insulin too high for too long.
I remember another one. Peak glucose at 1 hour was 160, but the insulin number went up to 200 at 1 hour.
Yeah.
So it bring the glucose back down. It brought it back from 160 to 140, 120 at the 2 hour mark. But the insulin took 200 units to do that.
Yeah.
That's something that you go with an OGTT that says 97 fasting, 160 1 hour, 140 or 120 2 hours. The doctor is going to say, well, you're basically okay. You're good.
Yeah. Even doing an OGTT. But missed the insulin
response.
Yeah. And also we'll see that 10 to 20% of folks, you'll miss significant insulin resistance if you just do an OGTT and you don't do the insulin response.
Yeah, like 10%. Yeah. Take DSR. Just thinking, if everything was good, why statin script? Oh, okay. So something here in the conversation with just thinking about prostate. So I'm just going to skip over here. It's going to be I'm going to take me too much to find the whole conversation. Harvey ups while under ADT. What's ADT? I'm not sure.
I don't know.
For PTA. I mean, we're doctors, but we don't, I don't necessarily
don't know all these acronyms. Yeah.
My body did not absorb vitamin D 10,000 units when I had a zero testosterone level. Zero testosterone level. Interesting. Fully documented blood work. I'm not sure what ADT is. It has to do with, it's not THR, replacement therapy. If you can clarify, Harvey, that will be good. I apologize. I'm not sure about those specific acronyms. Not a good trauma. Okay, so this is more like conversation between the two of them. See if there's another question we can. Okay, good. By the way, a fisherman tells how big his catch is with outspread hands, which was what Jesus did. Oh, okay. Like JV. Yeah, definitely.
That would be a big prostate.
That is a big prostate right here. Let's see if we can get some questions from non-members. We have like 5 minutes still.
Just real quick, this is where that was coming from. Justin said he went to a cardiologist last week. Everything looked good. Asked him about low-dose statins. And I said, I watched Dr. Ford Brewer. He said, yep, I know who that is. And he is correct, and gave me 5 milligrams. You know, we're hearing more and more of that from our patients. It's like a third of our patients that come to us on statins these days already come on low dose. And that just did not happen even just 5 years ago.
No, even 2 years ago.
Even 2 years ago. It's really amazing.
3 years ago, I started working with you. We didn't see that. We usually see people with atorvastatin 80.
Yeah.
Yeah. Well, that's hope right there.
Yeah, things are changing. Looking up.
Trip Presley, can you speak to the correct connections of cardiovascular disease and chronic kidney disease? It's frustrating to me that cardiologists and nephrologists apparent in silos and don't share information. Early diagnosis of CKD could result. It's very unfortunate. I think there's a clear beef between cardiologists and nephrologists. Have you ever seen Dr. Glaucom Flecken videos? He does some really crazy, funny sketches between cardiologists fighting nephrologists on the approach of cardiovascular disease. And it's reality. It's like, man, can you just please get on the same page?
It gets back to that thing. I think you called it the guacamole medicine.
Guacamole medicine, yeah. Oh,
now,
man.
What does guacamole medicine got to do with it? What is it? So it was a misunderstanding of whack-a-mole.
Yeah.
So if we had
times.
maybe we should go back and do a video on whack-a-mole medicine. So what that's talking about, that's not something that I came up with. I've noticed it. David Sinclair, I think, has the most famous lecture on it. And basically, there's a lot of academic lectures on it as well. And it's talking about how medicine is organized. It's organized by body part. So you got neurologists looking at the brain. You got ophthalmologists looking at the eyes. You've got nephrologists looking at kidneys, cardiologists looking at hearts. And for today's program, you've got urologists looking at male body parts. And all of them look at that one organ. But when you think about disease, that's not how disease starts. It starts with metabolism, especially, at least chronic disease. So it starts at a cellular level, not an organ level. So you get something like diabetes and prediabetes, an aberration in the metabolism that's causing a problem at the cellular level. It can impact multiple places. For example, obviously, the number one cause of heart attack and stroke, number one cause of blindness, as you mentioned here, number one cause of kidney disease. Nobody argues with that. Number one cause of heart attacks, number one cause of, well, there's arguments about the LDL versus blood sugar, but number one cause of blindness, nobody argues with that. Number one cause of kidney disease, nobody argues with that. Many of us would say number one cause of dementia. And as we're talking about today, I don't think it's the number one cause of prostate disease, but I think it's a much bigger cause of prostatic problems and therefore male urological problems than recognized. And it's the same thing. You know, everybody's focused on their little organ and they're not focused on the cells. And that's going to have to change. It will change at some point, but not in our lifetime. And I'm expecting to live for another 30 years, 40 years, 50 years.
That's guacamole medicine right there.
Guacamole medicine.
JMK 2921, do you agree that men over 70 years old do not need an annual PSA blood test? I agree. Routinely, that's not necessary. Maybe somebody who has kind of a significant history of having high levels of PSA, not being treated yet or whatever, that could be something. Also, if you're looking to live over 80, 90 years old, 100 years old, being metabolically healthy is probably more important. There are still some cases where you could miss prostate cancer traveling to the bones on the spine, but that usually happens before 70 years old. So it's better to prevent that. But I agree with JMK, not necessary to do that routinely after 70.
And that's one of the major standards. They don't recommend it after age 70.
Yeah.
Things are improving in that area. When this first came out, some of the findings about PSA, every urologist out there was, if you're a hammer, everything looks like a nail. And if you're a urologist, everything looked like a prostate cancer that needed to be removed surgically. And you had a lot more people with problems from prostate surgery, incontinent of urine, incontinent of even feces, loss of erectile function, all these things. Then you had problems associated with quote the cancers before they started doing all the surgeries. But that's really reversed. That's really backed up. The urologists have gotten a different perspective. When somebody finds a cancer in their prostate, they get really scared. And that becomes one of those issues where, again, Jesus and Fred and I are talking about going a little bit deeper into stories on how growing old is not for sissies. That's one of the places where growing old is not for sissies, knowing that you may have a prostate cancer and having to figure out what really should you do for it.
Yep.
And then one of the questions, and you get that recommendations from this standards committee, is don't even look, because there's no good answer.
Yep. And it doesn't decrease mortality either. That has been seen also.
You think we're going to get you out before 60 minutes?
Real quick, what's your recommendation on protein for people over 60?
There's a whole bunch of stuff about pros and cons. I do think we want more proteins. I think you got to be careful if you're doing proteins through a protein shake, because it can become a stealth carb the way the body treats it. I don't think I can cover. I think that's a 2-minute or maybe 10-minute discussion.
1.2 to 1.5 grams of protein for every kilogram, right there.
I'm not sure how realistic that is.
Well,
But
that
yes, I do think it makes sense to go. I have vacillated between, now that I'm low carb, I've vacillated between high protein versus high fat. There's issues with both of them. At the end of the day, I think most of us are still in an N of one.
oh yeah, for sure.
We have to figure out what works best for us, because I've flip-flopped on that too.
All right. Well, you make me fail. I think you just added that one to make me fail, because I was about to finish at less than an hour.
But now that you got me going, I can't. Okay, I can't help. I do have to say, by far and away, here's one of the concerns. You know, I've seen Peter's stuff. I've seen Ken Berry, and I can't remember Gabriel Lyons, and I know that the discussions where all these protein requirements were built on young men, and young men have so much testosterone in their systems that they could turn cardboard into muscle protein. I get all that. And so therefore it's not enough protein in the recommendation for older people, older men and women who just don't have enough anabolic hormones to create that. I live it. I'm 68 years old, and I noticed my own anabolic resistance. Anabolic resistance means your muscles don't grow the way they used to. They don't repair the way they used to. You can't just go to the gym once a week and stay fit in terms of your muscles. I think just like the issues with supplements, the issues with medications, there's too much focus on how much protein am I getting. Maybe a lot of focus on creatine. Creatine's probably maybe more important than protein long term. Maybe not. But the bottom line is all of those discussions tend to ignore the need for constant repetitive stimulation of the muscles. What am I talking about? Resistance snacks, high intensity interval snacks, rehit snacks. You got to do the work. You got to make your muscles burn more than once or twice or 3 times a week when you get into your late 60s, or you're just going to lose them. Bottom line. And if you lose your muscles, that's a big deal, because they're your best internal protection, safety valve against metabolic disease and prediabetes and diabetes. So you got me going.
Wonderful. I mean, yeah, you might as better just go ahead and do it. Before we go, there's one thing that I wanted to address, and I just didn't bring it up. If you would like to see a show about how to solve BPH, benign prostate hyperplasia, leave us a comment below so we know if that's something that we should be working on. Because we didn't really went in there other than saying, okay, metabolic disease, all the stuff we're talking about, but somebody in the comments was mentioning palmetto and some supplements here and there for that. So that will be an interesting topic to cover, but we want to know if you're interested in that. So if you're interested in that, put it on the comments. We'll be happy to work on that as well. We're hoping to post this Saturday, so stay tuned for that video about supplements that you should not be taking and what to take instead. So that's it. See you next week with Dr. Bernie, and see you there.
Hey, Jesus, before we go, I got another one. You got me going here, and so.
Oh, go ahead. This is another. What do you call that? What do you call that when you play another song after the show is over? Encore.
Oh, encore.
Encore
is Angkor what? That's a town somewhere. But anyway, this is a very, very important point. How often does a fasting glucose or fasting insulin fail to show insulin resistance when an OGTT does? With OGTT with insulin resistance happens all the time. I mean, I don't even know how many. I would say at least a third, maybe more often. But where somebody, I remember every week I get what? I don't know, maybe between like half a dozen people whose fasting glucose and fasting insulin or basal insulin are perfect. the fasting glucose is 80 to 90. The insulin level is less than 5. And you challenge them, and one or both of them just shoot out the roof. So, so when you hear somebody say, "Oh, the HOMA IR is the way to go, and you don't have to do all that other stuff," HOMA IR is built off of fasting insulin, fasting glucose, and it's wrong all the time. Don't depend on it.
Exactly right. And we know the numbers on fasting glucose, like it misses 50% of cases of pre-diabetes, diabetes. Fasting insulin, not so sure, because we see that often on people who are doing low carb, just like you said. If you're doing low carb, you have fasting insulin, fasting glucose, you're probably way better than most people. But the key is do the challenge to see how far you are, and what's low carb doing for you to keep those numbers low, and what happens to your body when you eat some refined carbohydrates or you eat more glucose than what you probably should.
Now, if you're saying these comments sound like a couple of crazy internet creators, again, both of us have far better credentials and background than you might know in terms of, I taught this at Johns Hopkins. Jesus is well trained in this space. We're seeing
the last 3 years is basically a residency program with me. I just need the title now.
But yeah, that's right.
I did a certification on metabolic health. So metabolic health practitioner though. So.
But where I was going was, it doesn't really matter about our credentials. The ADA says this. What are the numbers on fasting glucose and A1C for ADA? It's like they miss over half of it.
Fasting glucose 50%, A1C 70%.
So it's not us, it's the ADA. American Diabetes Association is acknowledging that these tests don't work, the tests that are being used.
Yep. We still have cases of people getting diabetes diagnosis after 5 or 7 years of the disease progressing, until they say, "Oh yeah, your glucose is too high." Yeah. Any?
You want me to finally be quiet now? I'll be quiet.
No, we're just leaving. Thank you so much. See you next week then. Bye-bye.